All right. And I'm recording. Welcome, everybody. I apologize for my tardiness, especially with such an esteemed visitor from afar. Thanks, Laura, for making the connection, although I think a few of us know Dr. Short. So we're really excited to have him here talking about perinatal HIV transmission and how to prevent it today. So I'm going to introduce him. Dr. William Short is an associate professor of medicine in the Department of Medicine, Division of Infectious Diseases at the Perelman School of Medicine. He graduated with his MD from Hahnemann University. He then completed an internship, residency, and chief residency in internal medicine, followed by an ID fellowship at MCP Hahnemann University. He's been actively involved in HIV clinical care and research since 2003. Dr. Short serves as the Associate Director of Penn's HIV Adult Clinical Trials Unit and the co-director of the Clinical Core of Penn Center for AIDS Research. He serves as a scientific member of the National Guidelines panels on treatment of HIV during pregnancy and prevention of perinatal transmission and the HIV primary care guidance panel. His research interests include investigations on novel antiretroviral strategies and comorbidities in people living with HIV. I will turn it over to Dr. Short.
Right.
I just realized, can everyone can see the transcription at the bottom, right?
I know. I
I'm
don't
Yes.
know how to ever, I never know how to get rid of them.
I think that's on me. I may work on it while you're going.
Okay.
I know it's lovely, but
Oh, I know
it's nice and accessible, but it can be a little bit distracting.
yeah.
All right, I'll turn it
Okay.
over to you. I'll play around with it.
All right. Thanks, everyone. It's so nice to be here. I'm going to try to share with you um, perinatal management really in the next 45 minutes. I just want to add one thing to my bio, and I think it's, because I graduated med school and by all of our training, I was out in 2001 doing a fellowship, but long before that, going back to the 80s, 1984 to be exact, when I graduated high school, I actually started my career as an RN. So I actually worked in one of the Center City hospitals where I did, believe it or not, and Laura, you know as well too, Hahnemann, where I did my nursing school, medical school. I was an RN there, and really that was a center where patients were diagnosed with HIV and actually left there because they were abandoned by their families. So this was all pre-AZT. So, yeah, I've been doing HIV care for quite a long time, and I'm going to take you through. So, here are my disclosures. An advisor for two companies, and I get research grant through Gilead that's paid to my institution. And my objectives are really to do a couple things in a short period of time. One is to look at where we are with perinatal transmission, and I'm focusing on the US because that's largely where my work is. I want to take you through the updates of antiretroviral therapy and how we got to our latest rendition of the guidelines, which were, as most of you may or may not know, delayed about 6 months. And the two things, I am going to come at this from an angle of an HIV provider. So I'm not an obstetrician, even though I sit in the obstetrical space, and I'm not a pediatrician, no way near. So you can see one slide, but I think it's important for how you manage someone who may become pregnant when I review the latest prophylaxis treatment and then infant feeding guidelines, and that's a highlight. So I just want to give you sort of an idea of what I deal with. And these are two cases, and I'll come back at the end and just sort of tell you what happened. I laugh all the time because this is, this field and sort of how I manage this group of individuals is really not part of my normal flow of my day. So it's really all things that I do, I say on the side. So I have a large clinical HIV practice. I work in the clinical trials unit, associate director, soon to be the CRS leader, and then CFAR. And then this is sort of the side thing I do, largely because it's not large volume, but you'll see the complexity in each of these patients that I'll talk about. So this was last Thursday, and this is a 100% true story. I'm not making it up. I was boarding a plane to go to Raleigh, North Carolina, and I got a call from our pediatric colleague that I work with closely, which I'll talk about at the end. And she was in a panic because she got a call from an outside hospital that 38-year-old cisgender female who was 39 weeks pregnant, had no prenatal care, basically presented to this outside hospital. They took her to the labor and delivery unit. When they did a chest x-ray to prepare her for delivery, because she told them, disclosed to them she had HIV, they went back through the chart and through care everywhere, would have pulled out a viral load that was over 1 million. And basically told her they wanted to do a cesarean delivery. She was not in labor, no ruptured membranes. When they did a chest x-ray, they saw in this woman from Sierra Leone all these abnormalities, and she told them she had TB, but they did not believe her. So they told her she would need to be in airborne isolation, and the baby upon delivery would be immediately taken from her, at which point she got up and left the hospital and then was on her own. And then they called pediatrician, who called me as I'm sitting in Philadelphia International Airport. And I'll tell you what happened there. It is a positive thing. And then here's another one. This 32-year-old cisgender female, perinatal HIV acquisition, had struggled her whole life with oral ARTs, very hypercoagulable. And it's a type of hypercoagulability I've actually not seen since I was a fellow. Multiple DVTs, PE with multiple areas of right ventricular strain, had been prescribed a direct acting oral anticoagulant, had been out of care after some domestic violence thing. We could not get her back, low CD4 wasting. And during one of the hospitalizations, I actually got her, brought her to the clinic upon discharge, started her on cabrelpivirine because she was going to die at her age. And now she has a CD4 count in the 500 range, undetectable, but basically is coming in pregnant now, lost her housing, living in a shelter, and that's these are the two easy patients I manage. So I think it's important to think about where we've come from and where we are now. Most people don't remember the historical part of this, and I think it's really important. Everyone thinks of 1981 as the time when, the cases were described in gay men and PCP-KS, but really, if you look, the first reported case to the CDC in 82 was a perinatal HIV case, and that was 18 months after the first reported case, and it's right there in the JAMA. By 83, reports of children started to come over that later were recognized that this is what this is, because they were born to people whose risk factors had been similar to those with HIV. And you could see it all described there. So no one knew what it was, but they had febrile illness, they had failure to thrive, hypergammaglobulinemia, depressed cell-mediated immunity, and a large number of those individuals died. And so we think, we move forward, and I sort of talked about in the beginning, there were no really interventions. There were no interventions to prevent transmission other than know your status and don't get pregnant and don't breastfeed. They were the recommendations. And they know once you treat it, and I think these are really important analyses, once you had a child and it was untreated, you could see here from Jackson Memorial in Miami that it was a 25% mortality by 2 years of age. And then over here on the right, you see this is from Africa. Again, 52.5% mortality by age 2. So we know untreated, something needed to be done. And then comes along AZT for treatment for non-pregnant adults, and they had certain criteria. And given that there were researchers and a lot of them were still available and people I still talked with, the one that I think most specific, and is really someone I idolize, is Lynn Matheson. And during that time, they basically said we have to do something. They didn't really know where transmission was occurring. Was it during the pregnancy? Was it at labor? Was it post? It was really all these different areas. And so they basically knew that AZT was toxic. They had a big meeting to come up and decide, how can we plan and how can we study this? And they came up with the Pediatric AIDS Clinical Trial Group 076. And, things that people don't talk about is they actually got death threats to the researchers who were doing this because they were going to do this. And I think for those of us who are old enough to remember what that time was like, there was so much debate, there was so much push, there was so much activism going on. And those people who were designers of this original trial were really met with a lot of confrontation. And also from FDA, they were required to they had to jump through multiple hurdles in order to get this study off the ground. But I think this really has set the landscape, and to me is one of the biggest successes. And I'll show you where they were sort of ahead of their time. So again, not knowing how transmission occurred, they figured let's hit multiple points, right? Because they didn't know anything. So they figured let's time pregnancy. And I think if you laugh when you see the dosing, they were given zidovudine 100 milligrams 5 times a day. And that was for in utero. So that was after the first trimester, because again, there was concern about giving zidovudine prior to that. They targeted labor and delivery with intravenous zidovudine, and that was pre-exposure prophylaxis, which again, thinking of the years in the 90s, 2012 is when we first got approval of PrEP. And then finally, they gave post exposure prophylaxis to the newborn for 6 weeks. And obviously, landmark results, there was an 87% reduction for those who got zidovudine compared to placebo. And really, the first demonstration of treatment as prevention. So, all this stuff was done. This article was published in 1994. So, long, long, long before we started talking about. But I think, and this is again courtesy of Lynn Moffisan, this is what happened in a very short period of time. And I just think, wow, these people were well ahead of their time. I mean, I didn't disrupt her slides because, you'll see terms in there like prevention of mother to child, which we don't use anymore. They're stigmatizing. We use prevention of perinatal HIV transmission, but I didn't want to alter her slides. And so the DSMB stopped the study. There was a press report. They put together a task force, develop a guideline panel, put it out. They explained the recommendation. They got a label change, published it in the New England Journal, and then Medicaid approved it, all from February to December. So, really amazing results that people don't really talk about, but it's really, really amazing that this happened in such a short period of time. One other piece of historical thing, because I get asked this all the time, and so I sort of have this slide that I put in. Everyone asks me, where is this, 1,000? Everyone talks about viral load of 1,000. Where does that come from? Because obviously, when you're treating someone, none of us want a viral load of 1,000. And so where it was is where they looked at this study. This is the women and infant transmission study, where they looked at rates of transmission and then they stratified by whether you got zidovudine or not. And if you go down here, when the viral load was less than 1,000, regardless of administration of zidovudine, you had no transmissions. So that's where this magical number of 1,000 comes when we sort of talk about when to recommend a cesarean delivery. So I just wanted you to have that as background. So what happened after ACTG 076? So here we are now, and obviously it's very fast forward, but and so right around the time, and it's sort of labeled, 1994 when AZT became standard of care, and then really outward, we move forward with triple therapy. The rates have dramatically declined. We added testing in entry into care, or preferably at the first trimester. We added repeat testing and all these other interventions, and we really have streamlined. And 22, here was the last data cut. And now we have data coming out. This is actually post-COVID, and we are still extremely low here. And we have reached the definition of what we call elimination. However, people in this field and space don't like to say that because they're afraid when you ring the bell and say success, that people start pulling away and then all these barriers collapse and then things start rising, and we don't want that to happen. So what is the current state of prevention? So what is success? What does it look like? So you saw the two cases, and I'll tell you right now, I have 20 with one that just came through before I started. So I have about 21 that I manage. And what is the success that we do? So obviously it's universal testing, right? So obviously the people that are referred into me are not. But once you get testing, and that really is first trimester or entry into care, I'm going to show you the data why this is important. It's ART for all pregnant persons and preferably started prior to conception. And I'll show you why that there's data to actually go along with that. Schedule a cesarean delivery or have a conversation around about anyone who has a viral load more than 1,000 near delivery. Infant ARV management, and that has really changed. It's going to blow your mind. I have one slide for it. If you don't do, if you're familiar with pediatrics, you'll be fine. If not, so much has changed. It just gives a Davy for 6 weeks. And then that goal is to where we are now. So let's start with the first piece. So this is what we call our U equals U, and I'll come to it. This is from the French perinatal cohort, and they looked at a large number of viral loads at delivery, timing, and then transmission. And they broke it down. And really, just to cut right to the chase, if you looked here, this is perinatal transmission rate among infants born to mothers, and these were all cisgender female included in this study, with viral loads less than 50 at birth. They looked at where you started the ART, and they broke up the preconception piece, which I think is really important because we lump everything together in the first trimester, but first trimester is 12 weeks, 13, 14, some people call it, but it's a long period of time. So preconception is really the critical piece because, neural tube closes very early on. So really this is what we want to know. But what you see is if you started and maintained a viral load less than 50 and kept that throughout, there was a zero perinatal transmission rate. Yes, there were confidence intervals around that, but zero is what was seen here. And then as you can see, as you go along, it's still all very low, but there is a change if you go, from preconception down to third trimester. And again, these numbers are extremely important to me when I'm counseling. When someone comes in and I get a call, someone's here, they're 35 weeks, they're newly diagnosed. Oh my God, what should we do? They're panicked. And it's like, just keep in mind, there's a lot of things you can do to get these rates down. And again, I think the key take home from this is zero transmissions when the person is suppressed at conception, continued ART through pregnancy, and then achieve that viral load of less than 50 near delivery. And that was really regardless of what ART combination was used. So ART, let's switch to that. That is really the hallmark of what we do, right? So antiretrovirals are really key. It's no longer wait till the end of the first trimester. It's really get someone on treatment early on. So there are a few general principles, and I always say, and Laura's been to our management conference, and um, it's a bunch of very smart ID individuals. They can tell you the life cycle of every parasite. They know every bacteria. When I come up and I present a pregnancy case, the room gets very quiet and people look at each other. Nobody says a thing. Pregnancy does something to, if you're not familiar with it, it scares people and people tend to really shut down. And I've seen that in the patients that are referred into me. But there's some just the general principles that you need to know. And hopefully by the end of this, if you walk away with that, then I've done my job. But pregnancy lactation or pregnancy potential should not preclude the use of drug regimens that would be chosen for people who are not pregnant, unless there are concerns. And I'm going to show you why this is, I say that, but keep in mind, I'm going to show you how long it takes to get some data. So I think that's really important. You do more harm by holding off on that. Persons who are present in pregnancy or an ART that is safe and effective, you should continue that regimen. And I cannot emphasize that enough. The drugs that are no longer used, stavudine, didanosine, that's a different story. We know about mitochondrial toxicity. We know they're toxic, especially lactic acidosis, all that. But in general, this bullet should really be your take home. If someone presents on a regimen, they're doing well, you should really think about not switching them and having a conversation. And that includes injectables, which we'll come to at the end. Avoid discontinuation during pregnancy. If viral load suppression is not achieved, we know this, do drug testing, and then all exposed infants now should receive appropriate prophylaxis. And I say treatment because we've changed our approach. Here's where the problem lies. When you're making decisions here, it's really a balancing act. And as Laura, or I'm sorry, Jill mentioned, I sit on the perinatal guidelines and I co-lead the ART section. And, I've had to learn a lot in a short period of time about how data is looked at and then how to make a decision. And so when we look at things, there are three basic things we look at. And the one is very easy, safety data. You're basically looking at, I'm sorry, not safety, efficacy data. Efficacy data is a given. So if a drug gets FDA approved, you have registrational trials. We do not look at efficacy data during pregnancy, only in the sense, which I'll show you when we look at pharmacokinetic data. But we want someone to be suppressed. So, for example, bictegravir, which I'm going to talk about, was our latest change. We know that bictegravir has multiple registrational trials. They gave it all its indications. So we put a check for that. Really, what's lacking is safety and pharmacokinetic data. And safety, because we want to look for birth defects, adverse maternal or pregnancy outcomes. And then obviously the big one is the PK data because of changes that occur. So these often lack when someone presents to us for care on a drug. I will not go through this, but 2 points about it. I think most people can quote and say, we know physiologic changes occur during pregnancy. But remember what PK is. There are four parts to it. The acronym ADME, ADME. So it's absorption, distribution, metabolism, and elimination. And I just want to draw your attention to a couple things. One is, metabolism. We don't often think, everyone says, oh, your volume and distribution increases. They say those little things, but there's a lot of other things that happen that impact sort of the outcomes when you're looking at drugs and levels. And so it's both enzymes, induction and inhibition. And when you look at drugs, you need to know how they are because these enzymes change over time. And one thing we sort of break it down in second trimester, third trimester, worse, that this is a continuum. This starts during pregnancy and it continues throughout the pregnancy. It's not like you get the second trimester, bang, there's your end. They start changing over time, and this has been well published. So it's important to know that these things are going to impact the disposition of the drugs that you're using. So how long does it take to get that data? Angela Colbers did a really great job showing that from the time of FDA approval for all the drugs, how long did it take? There's a median knowledge gap of 6 years. So what does that mean? You have someone, and I'll use bictegravir because everyone uses that the most. So bictegravir was on the market, approved in 2018. It's actually a little shorter period of time, but we just raised it. So 7 years later. So it takes a long time to get these studies up and running, and we can sort of strategize what's best to do this. Should these be done during the registrational trials when someone becomes pregnant? That's what we're pushing for. Don't exclude people of pregnancy potential or pregnant, but they are still done. So I followed in Angela's thing and said, well, what about safety data? How long does it take? And I got the exact same thing. It takes about 6 years to get that data. And this was recently published. And again, you can see drugs here we have almost no data for. So it's really important for us. I'll talk about the pregnancy registry in a minute because it's one of the important ways we look at safety data. But again, 6 years from the time a drug is approved to get a PK as well as a safety study. And hence, we have patients who are presenting, and that's why monitoring is so important and what we do in the guidelines when we're sort of going through the data. I will just bring your attention to this. I think most people were aware that this happened. It's almost like, where were you at? I had walked into management conference in March of 2018, and the news had hit that when they went through the Sapamo study, and it was interesting because they were looking at efavirenz, which had been the bad drug that people were really concerned about, and they looked at preconception or periconception exposure of dolutegravir. They found that there was a high rate. It was only 4 neural tube defects, but a signal there that something was wrong with neural tube defects. And I don't know if anyone remembers what happened, but it really led to a lot of recommendations. People were switching drugs, and during that time, I realized, sometimes when I give this lecture, they're very basic concepts, but I realized unless you deal with this, you really don't remember. Don't change someone at 14, 15 weeks of gestation. The neural tube's been closed way back 4 or 5 weeks after your last menstrual period. It's not going to matter. That neural tube is already formed and closed. So people did a lot of different things. And what you see is that from 2018 to 2022, it took all this time. And what you note changed over this time is the number of exposures. So you went from 494 during the initial report to almost 10,000. And that's really what narrowed. And I'll show you there's some guiding principles when I look at the APR, and that makes total sense. Neural tube defects are rare defects, and so you need a lot of first trimester exposures to be able to detect it. It's very simple sample size calculations. And now in 2022, it is actually the preferred regimen for all periods, dolutegravir through pregnancy. But again, that signal led to concern, and again, all related to lack of safety data when a drug was approved and marketed. So the prevalence of neural tube defects born to women on DTG had declined to 0.11%. So it really does not differ when you look clear across other drugs, not preconception. So it really now is back to the baseline. So now let's take this and translate it into the guidelines. Sorry, I'm talking fast. I just want to get through everything and leave time for questions because there's a lot to cover. When we look at drugs, we classify them in a couple different ways. The two that I think are confusing for individuals are, is a drug preferred or alternative? And this sometimes for us, every time I'm making a decision, I have to pull these definitions out. They sound very basic, but they're not. And we argue among ourselves before we send things out for a vote. Preferred means that you have efficacy, durability, tolerability, its ease of use, and it's all been demonstrated in clinical trials. So we talked about that, right? So once a drug's approved, that's your check. But to get moved up, you specifically need drug and pregnancy specific pharmacokinetic data. And I will add to that, not in abstract form, in peer-reviewed form. And that's what really delayed BIC, is because we had one from Gilead, we had an abstract form without free drug levels from Impact, and that led to being classified as alternative first, then moved up. But that needs to be available. Favorable risk benefit balance, and then safety outcomes. So that's what makes it preferred. If you have some clinical trial data, you're starting to get some PK, that's when you can move it up to alternative. And alternative doesn't mean you can't use it. It's just, it's not the preferred. And especially when you're talking about starting. So I thought I'll just talk you through really only the big piece to show you how the decision was made before I turn it over into infant feeding and prophylaxis. But the major changes to the guidelines that occurred this year were that bictegravir FTC TAF was now listed as a preferred regimen. We did move abacavir down, and one of the things that I really wanted to do when I got on the guideline panel, because it was so frustrating to me as a clinician, is when I looked at the adult guidelines, it said X, and when I looked at the pregnancy guidelines, it said YZ, and nothing matched. So we've done a great job of trying to really make things match. So we know abacavir is not preferred for a couple reasons, but one of the reasons here we chose to move it down to alternative was you have to wait for HLA tested if you don't have it. And so anything where you have to wait and delay, we don't want to make that a preferred regimen. So that's why, and that's all I'm really going to say about abacavir. But I really want to focus on BIC for a few seconds. We had the efficacy data. There were 3 pharmacokinetic studies done. I should have put the PANA first, but the PANA network presented, they were the first pregnancy PK studies. There was an N of 2. They basically looked at the area under the curve of the second and third trimester, and you could see they were decreased. They came up with high transplacental flow, so that the levels go across, and all were suppressed, all 2 of them, and no transmissions. And that was followed by the 2 studies I mentioned. So one was through Impact. It was a phase 4 study, 27 individuals. You could see the decreases. They're all very similar. The key here, and this is what we reviewed, and we work with, pharmacologists on this as well. The trough levels, which you worry about, were above the protein adjusted EC95, and that level is 0.162. 3 participants did fall below. And again, similar to this, you had high transplacental passage. What we did notice that majority of people were suppressed here. There were no transmissions. And the other thing was, for those 3 that were below this threshold, they were virally suppressed. So even though they had lower levels below that threshold, they were still suppressed. And I don't want to read the same thing, but Gilead did the same thing. They showed that their trough levels were 6.5 greater than the protein adjusted EC95 at all, 100% suppressed and no transmission. So these were all out. They were published in peer reviewed journals, and we struggle with this a little. And what we saw is that, the next thing we say is, okay, well, yeah, pharmacokinetics, how did that translate? And we looked, and here 90% were suppressed, all were suppressed here, 100% suppressed. And then a group of us, I didn't put it in here, got together and did a retrospective review of all of our cases of BF TAF and looked and saw very high rates of suppression. So we didn't have PKD to match that, but that was more real world outcome data. So as a result of that whole combination, we decided to move this up into the preferred category. Along with this, I know it looks very horrible at this early hour of the morning for you guys, but I just want to tell you at least one thing about this. So the APR is what we have to monitor safety. And I remember the first time I sat on this committee, I thought I was dreaming. I'm like, I'm an ID provider. Why am I talking about neural tube defects and all the things that I knew nothing about? And I learned a ton over the years. And so this report comes out twice a year, and it's updated, and it really relies on providers to report. Providers report exposures to the registry, preferably before the outcome is known, and that gets included in the primary analysis. The problem is this is uncompensated time, so most providers don't do it. It's about 10% of providers in the US report here. We're trying to work on better ways of collaborating thing. The big example is lenacapavir. We're trying to get the purpose data, all the pregnancies that were in there. If there was an agreement and it sort of fits, that it comes on board, because then you don't have to wait 6 years for that data. And basically what we do is we look at first trimester exposure and compare it to these 2 population comparators down here. I will not bore you with the details, but I will tell you that um, bictegravir was done, and we saw that there was really no specific defect that stood out. We looked at the prevalence. You can see here there was a little concern here with the upper bound when it looked at the metropolitan comparator. So what we did then is we looked at all the birth defects because again, there were 33 defects, and we do this rule of three to see if any three things stand out, and there were none. So we felt comfortable saying that over time, like Sapamo, as this denominator grew, this confidence interval would narrow out and we wouldn't have any concerns. So this is where we base a lot of our safety data. I'm just going to say one other thing. In order to be included in here, you need to have 200 first trimester exposures. And the reason is why, when you do a study for sample size, that it's very similar. 200 first trimester exposures gives you 80% power with a 5% type 1 error to detect a twofold increase in overall birth defects that are in around 3%, right? And then, like I told you earlier, when you're looking at rare things like neural tube, you need over 2,000. So if you just kind of go down here, you look, you say, wow, lenacapavir is not in here, cabotegravir is not in there. That's right, because we don't have that data. And when you look here, I mean, we can't say bictegravir doesn't cause neural tube defects. We don't have 2,000 exposures. So there are limitations to this, but this is what we have. And this is why we beg people, please, please, please report. So here's where we are now in terms of guidelines. And this was as of June 2025. So these were available at the end of November last year, but there was a lot of delays. And so we finally got them out and we're working on our next edition. So for antiretroviral naive, we now say BF-TAF is preferred and DTG plus whatever form of tenofovir with either 3TC or FTC. And that's where we are. So it's INSTI-based. It's sort of very similar to what the adult panel has, which is really great because then if you conceive, you continue on, there's no questions. The only problem comes up is when you have a history of long-acting CAB for PrEP. So you want to get genotype testing. Here you're going to go to darunavir until you rule out INSTI resistance. And here the darunavir, the boosted darunavir would be BID, again, based on pharmacokinetic studies with, again, same two nucleoside backbones. So that is the one difference here, the one time where you would use a PI. And then I have a whole list of alternative regimens. I will just quickly say one thing on two drug regimens. So if you go back, and this is something I can't share fully, but I think in the next iteration of the guidelines, you'll see there's something that may surprise you. So historically, we have used three drug regimens to treat pregnant individuals. But when you look at the criteria, so I'm just going to use DTG 3TC, the criteria are efficacy data from non-pregnant adults. We have an enormous amount of data on DTG 3TC. We have Gemini studies, we have real world studies, we have Tango, Salsa, Pasodoble. I could go on and on. So the question that was challenged by myself and Lynn Moffason is, why then can't we use this? We have excellent PK data on dolutegravir, excellent on 3TC. Go back to here. Here it is, lamivudine. It should be here right in somewhere in here, but very high rates of exposure, 5,000 exposures. Why would we not use that drug? And we have from dolutegravir the data from the registry. We have Sapamo data. There's Eswatini data, thousands of exposures. So the question is, should that be moved up to preferred if we're not looking at efficacy and viral decay is the same with 2 versus 3 drugs? And I'll leave you to wait till January for that. All right. So what do you do here when someone becomes pregnant? And I cannot emphasize it again, continue the current ART regimen. Have a discussion. Make sure you're made aware of pregnancy data. We've made this very clear in the guidelines. It just would say monitor more frequently. We gave you guidelines every 1 to 2 months during pregnancy if you're on something that's not preferred. Obviously, if you switch, you want to do it more often and something that's not recommended. I think 2 drug regimens we just spoke about, that's changing. Cabrolpivirine, I'm going to share at the end when I show the case that I took care of, and then sort of some data that's out there now. And lastly, cobicistat. So cobicistat is the one sort of one where were heightened too because there were pharmacokinetic studies done with both boosted L-bictegravir as well as boosted darunavir with COVID, in that COVID levels as well as the parent ART goes down. So you're losing the COVID effect, which is boosting, as well as the other one. So here's the one where we say really consider switching. Having said that, we have looked and virologic outcomes are actually pretty good if someone continues to stay on it. This is just what I mentioned there, and I left that for showing the pharmacokinetics considerations. One word on zidovudine, because this often gets asked, what about IV zidovudine? And the guidelines changed a while ago. When someone gets to 34, 36 weeks gestation, we check a viral load to determine what the mode of delivery is. And again, this is all assuming there are no obstetrical indications for cesarean delivery. If the viral load is below 1,000, again, that threshold comes for the women infant transmission study, we recommend that there's no benefit of having a cesarean delivery. Continue their regimen, and then they would go to IV zidovudine. Well, the recommendation came out that if you have drugs that have high transplacental passage that are going to be accumulating in the fetus, they already have drug levels, which is what zidovudine's doing. It's crossing over, it's accumulating. So it's pre-exposure prophylaxis before you have a delivery and exposure. So the question is, if you have that, do you then need to give IV zidovudine? And this is a hard sell for a lot of people. They're married to this. It was part of the protocol. It's like anything. We're afraid to break away. But they basically have gone to say that you don't need it. And so when I worked at my previous institution, we did not give it to anyone that met certain criteria. When I got to Penn, they were very hesitant, and it took me, I think I've been there 10 years. So finally, 7 years in, they asked me, do you want to revisit this? And I said, it's your call. I'm not going to argue on this. It's what you feel comfortable with. And so what we do now is IV zidovudine is not required when you have all of the following criteria met. If one, the person's taken antiretrovirals, if the levels are below 50 within 4 weeks of birth, and then adherence to the regimen is achieved. One of the concerns is in the Green Journal, which is the OBGYN journal. They came out with data showing that, which I thought was really fascinating. And you could all imagine when we have patients in our clinic that leave. I mean, I just had someone tell me, I see you every 4 months, just so you know, as soon as I leave, I stop all my meds and I don't take them. And I know when I'm coming back, which I know most of us think that could happen, right? But they did this in OB where they measured that viral load at 34 weeks, and then they tested at delivery, and there were some who had, they had viremia. And so the OBs at Penn have changed the first or the second criteria that they must have had viral suppression throughout the pregnancy. And again, that's fine to modify. But again, the guidelines are this. And I think, Heather Watts sat at the stage once and told somebody, do what you want. Don't make a big deal of it. Don't stress over this. If you want to give it, just go ahead and give it. I think the time, if you're not familiar with timing, especially if you're doing a cesarean delivery, you want to do a load followed by a meg per kg per hour for 2 hours. So you need 3 hour lead time. That's a delay. All right. One slide on infant treatment and prophylaxis, and it comes right out of the guidelines. So as you can see from this, it has changed a lot than just give zidovudine for 6 weeks. So the guidelines now say if the viral load of the pregnant person is more than 50 at any point after 20 weeks, if it's no, you go to zidovudine for 2 weeks. Our clinic still does 4 weeks. They feel the data is better with 4, but the guidelines say 2. What happens if yes? Did the viremia occur in the 4 weeks prior to pregnancy? And you go down these pathways, and basically you could see it really involves, especially these latter two on your left, making sure you get a birth nucleic acid amplification test with presumptive 3-drug therapy. And so how do I come in this? And why am I even bringing this to you? So you'll hear at the end when I talk about our collaboration, what we do is basically I see the patient all throughout the pregnancy. I know where they fit in this thing. So when I come to the meeting, because the pediatrician's off at another site, I bring this to our meeting saying, hey, this person meets high risk based on XYZ. Person's born, they know, get a day of life PCR, get the person on 3 drugs. And one other thing to throw in there is Our three drug combination is zidovudine, lamivudine, and nevirapine. Again, for new providers, those are very old drugs that don't use. I unfortunately prescribed them during my fellowship. Nevirapine is an NNRTI, and so one of the things I have to go back and do is look through the pregnant person's chart. Is there a history of NNRTI resistance? And at that point, we would consider not giving nevirapine to the newborn and using raltegravir. Problems with raltegravir because UGT metabolism gets revved up after birth, so you constantly have to change the dosing, and it gets very, very complicated. I think most of you know that in order to say that a newborn is HIV negative, it's really based on that 4-month PCR that they do. But again, I think you see here very, very complicated decision making here. All right, I'm gonna go a little faster through this because I want to get through questions. I'm leaving you with this, and I'm happy to share the slides. This is a person that I won't talk about, and she's free to share this. She shares it. Her name is Cece. If you go on the next slide, I left the YouTube link. It's only 2 minutes. I encourage you to find it, listen to it. Again, I'm going to send these to Laura because this is someone who's living with HIV who was mistreated during a period where she wanted to breastfeed. And she tells her story, and she wound up in Philadelphia. And we were able to take care of her and really undo a lot of damage that was done by being told what she could and could not do. So I will leave it at that. What has changed, and this has been a very big change, is that in 1985, it was recommended that you do not breastfeed. And, again, a little historical perspective here. You see these terms that many people probably don't even know, HTLV3 and LAV. These were terms that were used prior to naming it HIV. Basically, these are the things you would not do. You would not get pregnant. You would not breastfeed. And then in 2015, the guidelines sort of took a little bit of a still not to breastfeed, but sort of dig into why this is important. What are the motivators of why someone would want to breast or chest feed? And then in 2018, they added when someone decides to breastfeed, despite counseling that we didn't have at the time, that counseling, consider and counsel use harm reduction measures to minimize the risk. And to me, this big thing was not walking in and telling someone you can't breastfeed and then they walk out, stop the ART and breastfeed. It was really working with them like we do with all other harm reduction measures. And then finally in 2023, the guidelines really took a major shift. And I'm just going to point here to say the primary recommendation was to support parental choice through shared decision making, not a specific mode. And you'll see in a second how I approach this because I'm usually the first one to see them. And it's really a conversation that I think is hard, but I've learned how to do it over time. And it's really become one of the key things that I do as I walk into the room for the first time. I just think this is important for you to see, like, what was the process of this change? So why did it make such a drastic change? A lot of community input. Those who may or may not know about the Well Project, these are also groups of international women living with HIV from North America and throughout, lactation specialists at the CDC. This led to a collaboration between the perinatal guidelines and the pediatric guidelines. And then CDC, instead of making their own guidelines, referred to the perinatal guidelines. And then the American Academy of Pediatrics also came out with their guidelines. So this has really been an evolution over time. The question that comes up is, and this is where a lot of pediatricians get, not only pediatricians, but pediatricians in particular, they get very concerned because we all talk about U equals U. And so does U equals U apply to breastfeeding? Well, I told you we know preconception, if a partner's living with HIV, take an ART, has that viral load less than 200, they're not transmitting. Same thing for pregnancy. I showed you the Mandelbrot data. U equals U if you're on ART prior to conception, undetectable throughout, and delivery, 0. Postpartum is not. There's a lot of variables. And I put this here. This was done in Philadelphia. It's older data, but I can tell you it's still relevant. We looked at the cascade of care. When you're looking at the number of deliveries and you're looking at suppression, and you basically look up, pregnancy wise, and then retention in postpartum 1 year, viral suppression. And if you just start going out, look at viral suppression at 1 year, 31%. And other studies have been duplicated. We're actually in the process of doing this now again to see where we are, because this is extremely important when we're talking about infant feeding. And you'll see the data in a second. So the cascade is terrible postpartum, and that's when studies are being developed. There's a study now that was supposed to be done through the ACTG that was stopped largely because we couldn't get the rilpivirine, and it was actually looking at giving postpartum long-acting rilpivirine to prevent this, right? So if you're going to, breastfeed, retention and care, and the study was stopped and thank God picked up by dolphin investigators. So it'll be dolphin 3. We'll look at this exact thing. The transmission of HIV through breastfeeding, this was all prior to ART, was very high over 2 years. So that's why all the initial recommendations were no. What we use now in counseling really comes from the PROMISE study that was done through IMPACT. And again, I'll cut you to the chase, and the chase is right here with the checkbox. But there's 2 points about this. So this study looked at giving prophylaxis to the pregnant person or the infant. It was not both. And that's something we do. And so when we're trying to extrapolate this study to what we do in clinic, we also say it's probably lower. We just don't know because we don't have the data. So they basically gave prolonged infant, it was nevirapine prophylaxis versus given maternal 3TC, TDF, and this was lopinavir ritonavir. And these were the transmission rates: 0.3% at 6 months, 0.6% at 12 months. And that is what we use when we do counseling. And the data on mixed feeding, where you're going back and forth, this is all pre-ART. And so we really don't have any good data here. There's a lot of counseling that goes on with our pediatricians about this. Does mixed feeding apply? And I think people are getting more and more comfortable with this as we move forward. I don't have to tell you this. I just want to go through my last 2 slides. So I want to leave you with this 2 things from this slide that are important. You want to start with open-ended questions. So when I walk in to see someone, one of the things I say is not, you can't breastfeed, you don't want to breastfeed. I say, what are your thoughts on infant feeding? I really leave it open because I think that's what's important. And a lot of times they get back, well, I'm not allowed to breastfeed, am I? And so that's already, they know that I'm going to come at them with that. So I think it's very important to say, what are your thoughts on infant feeding? I give them the information, and I can tell you a lot of people still say no. If there's any chance, if it's less than 1%, I can't do that. I want no part of it. But it's important to have that. One of the other big things that it's in red here is not to involve or threaten to involve CPS. And I know that sounds like nobody here would ever do that. It is done. We hear about it all the time. I'm on multiple different groups and listservs, and we hear about this all the time. And when I do presentations, people say, we would call DHS, we would call Child Protective Services. So the guidelines clearly say do not do that. And the last thing is, what do you do for prophylaxis? For infants, there's no guidance on this. So at the Children's Hospital of Philadelphia, what they're doing is they're given zidovudine for 4 to 6 weeks and then daily nevirapine until 1 month after the cessation of breastfeeding, with viral load monitoring monthly. That's not a standard. That is just what we do. And I'll sort of show you um, what our data are. So this is the last 2 or 3 slides. So I cannot emphasize collaborative care. I think if you've seen anything, I've talked a little bit about OB, I've talked a little about pediatrics, case managers. Collaborative care is really the way to do this. And I laugh because I love doing scientific presentations. I love talking about data. And I had to do this talk once at a City Match, which is a large, maternal child pregnancy conference, and I thought, my God, this is going to be terrible. I had to make graphs like this that I like Kaplan-Meier curves, and so I got up there and I made these slides at the last minute, and the line was out the door because people wanted to talk about this collaborative model. And I think we all know what collaborative models do. The goal of all of them is to improve clinical outcomes. And in my last slide, I'm going to show you that. So when I got to Penn in 2015, one of the things I asked for was I wanted to be able to collaborate with the maternal fetal medicine department as well as pediatrics and sort of merge the practice, because historically in Philadelphia, Penn was not a place that people talked about fondly in terms of this care. And so I got there in 2015. I met with the leaders in the maternal fetal medicine space, We came up with it. I would have a collaborative agreement with them, and I would sit in their practice. So we made Tuesday afternoon our clinic. We were able to establish that, and then we linked, and sort of got involvement with pediatricians. And then we do monthly collaborative calls. We discuss and coordinate all the care for upcoming births and the recent births that just happen to make sure those people are linked to care. They have a provider. We have 60 to 80 pregnancies per year that we're seeing at Penn. And then CHOP also gets outside referrals. So 99% have delivered with a viral load less than 200, 95% less than 20. We had one recent transmission about a year ago, but this is someone who walked in, no prenatal care, ruptured membranes at 25 weeks in labor, and was diagnosed at labor. So obviously, you can see sort of fell out of the realm, but the baby was positive and is positive and doing well. And I got our numbers. So since 2023, we've had 30 persons breast or chest feed with zero transmissions. And again, this collaboration between, medicine, ID, Children's Hospital, pediatrician, special immunology, and Action Wellness is our perinatal case managers. This really has been brought about through this. And so you'll see, the last cases, here what happened. So this is our case of TB. And what happened here was we were able to get her into care. She was brought to the what we call the perinatal evaluation center, admitted to labor and delivery. They knew her history of having treated TB, which is what she had. She did not go in isolation. She had a cesarean delivery. Baby had a day of life PCR that someone from the ped staff walked down. All this happened within 24 hours, and the first test for the newborn was negative and linked back to care. So that was a result of a lot of coordination. This was the other case. This was a patient that, we talked about with cabrolpivirine, and, a long discussion. If you go back to the history, this is a person who struggled with oral ART. I discussed there's no data on it, but she wanted no parts of, oral ART. And so we left her on that. We switched her off for DOAC. We're still seeing her. Her CD4 is in the 500 range. She's undetectable and doing very well in her end of her second trimester, ready for the third. I'm not going to cover, this is data I presented because I'm out of time. I just want to leave you with final remarks. But, there's, again, lack of data in that long-acting space. So to sort of conclude, is that it's a very complicated field. And so this article, and not to sort of promote our publications, but sort of looking at what we do, I gathered a group of experts from, sort of around the US and said, each of them had specialties in certain areas. And I said, let's put this paper together. And we put this paper together, and it was just published this year. And it was really around all these things. So it's not so much HIV, it's how to navigate all these complex things. So in this, we cover what I call choice of antiretroviral therapy, prophylaxis treatment, because that's all changed. And then we added, what about perinatal health among pregnant persons with HIV? There's a lot of that. Substance use disorder. How about those who are living with HIV? They were born, they have perinatal acquisition. It's a whole set of things. How to manage the postpartum period, and then infant feeding. And this is really a resource that will help you with a lot of different things. And I think I did that with time for questions. So I thank you. Hopefully that was informative. I'm actually going to stop sharing so I can see people. It's kind of weird looking at your slides, but so thank you all so much for your attention. Thank you.
I'm going to make the clapping sound.
That's a good thing.
I want to open it up to the group before I fill in as needed.
And while you're waiting, I could tell you, while you're waiting for questions. So the cabrolpivirine, and again, I'll share the slides, the data, it's a case series of, there were 31 in that one. We now have 40, and we have another 10 we're going to add. Was really just looking at anyone who had an exposure. I have a database that I'm looking at, because the cabrolpivirine, well, PK study from Impact is not open yet, and we're still waiting for it to open. I don't know if anyone here is involved in it, but it will be opening. So we're not going to have data for a while. So I thought it's really great that we should start accumulating at least virologic or outcomes. And so we have that data. So we have data on people who started, who conceived on cabrolpivirine, those who started because they were not viremic, and we have outcomes that really a lot of people got to undetectable. There was one, but they waited till 36 weeks to give cabrolpivirine, and the viral load literally went from 150,000 down to 2,500 in 1 week. And if they would have probably done a little sooner, they kept changing ART. But I'm hoping people can learn while we're waiting for the PK. So, and more's coming. I have another analysis coming for Croy this year. I think, Tom, I see your hand up.
Yep, Tom first.
Yeah, thank you for that amazing talk. It was really, really
I'm
interesting.
sorry, it was a lot
I
an
don't work
hour.
in
I
the
was flying.
yeah, no, I don't work in the pregnancy space, but I was really shocked by that postpartum continuum of care slide that you showed. That is unbelievable. Can you speak as to some of the work that's gone in to look at potentially the causes of that?
Yeah.
And is there a move? Is this a social support question? And is there a move to try and improve social support and address some of those underlying causes?
Yeah, it's a great call. Yeah, I mean that's why we're repeating that data because that was so when that came out. I mean, Dr. Montplaisir, who I know, Laura works with. I think you two worked together at the same time. She really did that analysis, and they did a subsequent analysis where they looked and saw that if you had a perinatal case manager attached to you, your rates of retention and viral suppression were higher. Anecdotally, I could tell you from my own patients. Patients deliver, they have to go to Children's Hospital of Philadelphia, right? So they're going there frequently with their newborn. They're managing being a new parent. And so HIV care is less. And, then again, just what you said, it's all the other social barriers that are in there. And so that's where our case managers, and again, these are things I pray for when we look at cuts that do not go away. These case managers help to get them back in care. Our collaborative meeting, when we're on there, we're saying, patient X delivered. Has she or he been linked back to their provider? Have they had an appointment? And we get all that together so we can do that. But I think the problem is not everyone has this collaborative model. So, patient sees their HIV provider, they see the OB provider. When that delivery occurs, then they go to pediatrics, and pediatrics may not have a link back. So it's really about coordinating that care all together. Yeah, it's a very complicated space, and I will say that that's Philadelphia data. There's other data in the U.S. and there's a series of data in low and middle income countries as well. It's really, and that's why that cabrolpivirine trial was going to be so instrumental. It was Risa Hoffman with and Sharon Shaheen Lockman were leading it, and when it got squashed, all of us were, I mean, we were very, very upset. Like, you got to push this forward. And I have data. I'm going to try to put out a case series on that of at least 5 or 6 people who really did terrible after delivery. And then I transitioned to cabrolpivirine and they've been engaged in care. I mean, it really does. You have to come in for injections, appointments, viral loads, and it really does change things. So I think Lucas was next. I mean, I know Lucas.
Yeah, and just it's 9 o'clock. There are two more questions.
Yep.
Three questions. I don't know why everyone takes so long to ask their questions. Lucas, if you can do it quickly, and then we'll see what else we can.
Yeah, real quick. It's maybe
Sorry.
not a short answer, so that's okay if we want to skip over it. But just along the lines of chest feeding, I'm just curious because we have women for obvious reasons who want to transition to cabrolpivirine after delivery, and although it's a very low rate of failure on cabrolpivirine, it's not necessarily zero. I'm just curious if you have women who are on long-acting injectables and they're chest feeding. We don't give the baby prophylaxis typically, like you guys are at Penn, and the discussion around that low but not zero rate of failure and how those conversations go while they're
Yeah.
chest feeding.
Yeah, very complicated. We it's funny, we just had two deliveries last night and this morning one is delivering both on injectable and both who are going to breastfeed. So what do? We still do the weekly, I think we keep in touch with pediatrics. We make sure they're getting on-time injections. And I didn't really talk about it. I know we're running out of time, but PK modeling suggests that monthly is probably the better way to go because of rilpivirine, not the cab, but rilpivirine. These are all on every 2 months. I did not change them. They were virally suppressed throughout the pregnancy. So it does become a concern. It's hard. I think we can talk offline about that, but I do see the other side where you get them if they're struggling with adherence. That's the way to do it, because then they will stay suppressed. But I hear you about the failures. I
Yeah.
agree. And again, it's all balancing, and it's very frustrating. They're data-free zones, which make it very complicated.
Yeah, thank you.
Sure. Do you want me to?
I think we really, unfortunately,
That's
don't.
fine.
We've been trying to be better about this. It'll
I'm
be.
going to put my email.
Yes, I think
and you
that would
can-
be great. I mean, I think the first question from Gigi, the answer would be PrEP.
Yep.
So I answered that, but anyway, that's a whole other lecture, of course. This was so helpful.
Thank you. Thank you.
Like, what
I
a
worried.
great
I
summary.
stressed over this lecture because I'm like, I don't know what they want to know. Is it going to be too
No,
little?
you did it. You nailed it. So
Thank you. Thank
so
you.
much.
So thank you all so much. And again, please email me and I'll share my slides with Laura. Please feel free, and please look at that video. It's worth the 2 minutes of your time.
Thank you.
And Susan, nice seeing you. I'm starstruck.
Bye, everybody.
I'm going to come up to you at Croy and say hello.
Thank you.
All right. Thanks, Laura.
Bye-bye.
Bye.
Have a great day, everyone.
You too, Bill. Thank you.
Bye.